So I think the triple negatives with African features tend to be the HER2 enriched subtype samples that are in the triple negative group. So there are what we call HER2 enriched, HER2 negative. And many of those have the African features. And the African signature that was published years ago. There are a few luminal A's in the triple negative group, and those are, if you go in and look at the IHC, they're typically low, but those usually also have a discordance between the mRNA and the protein, and I don't, it's hard to say which one's right? Because by by 50 genes or even by 150 genes, those luminal A's look like luminal cancer. And they actually typically have mRNA for ER and PR, but then by IHC they don't. Right? So maybe the gene's not being translated. Maybe it's a technical failure. We don't know. But there's always a discordance rate.
Большое спасибо за ваше сообщение. Я патологоанатом. У меня несколько вопросов, но, насколько я понимаю, для аудитории, для нас, в принципе, актуально то, что мы сейчас больше узнаем те белые пятна в базально-подобном раке. И, наверное, все-таки классификация, как мне представляется, будет меняться и добавляться все больше. Вот первый вопрос. Скажите, пожалуйста, как вы считаете, чем объяснить сопоставление серозных аденокарцином яичника, плоскоклеточного рака легкого и таковые найденные находки при базально-подобном раке молочной железы? Эта уникальность связана с подобием стволовой клетки, в данном случае базально-подобные клетки молочной железы, либо это унификация какая-то идет, какая-то больше, скажем так, связанная с изменением структуры вообще самой опухолевой клетки. Мы о ней, может быть, еще не знаем. Как вы считаете, чем это объяснить?
So, this is a theory. And I think your first suggestion is the theory I would agree with, that they have stem-like features. The hypothesis would be they are derived from a similar cell type. And certainly there's data to show the genetics is very similar. And so somehow that stem cell, or that common cell type, is sensitive to loss of p.4, loss of RB, widespread chromosome changes. But then these widespread chromosome changes are in the same places, right? So gain of chromosome 1, loss of chromosome 5, gain of chromosome 3, right? So there's other things that are being amplified and deleted that are common between those. But I think it is this, common cell type that has stem-like characteristics.
Сейчас такой вопрос. Но мы знаем, что в Галине обсуждаются различные классификации, в том числе МГТ-DX, амстердамская генная сигнатура, ПАН-50, обычно голоса, в смысле предсказания химиотерапии, в пользу МГТ-DX. Но ПАН-50 продвигается очень быстро. Недавно была какая-то публикация, которая касалась проекта Тейлор, основанного на МГТ-DX. Нет ли там контаминации, это все рецептор-позитивные опухоли, контаминации твирдо-негативными опухолями и хердопозитивными, которые определяют, допустим, чувствительность химиотерапии при высоком риске по МГТ.
So you might be talking about the paper I had with Rich Gelber, and And in that paper, we basically simulated the Taylor-X studies and then looked at how many non-luminal tumors there were. Right? So how many HER2 enriched and how many basal are in a study of ER-positive breast cancer. And then we tried to estimate the contribution to the overall chemotherapy benefit coming from those non-luminal tumors. And it was significant, but it wasn't enough to explain the overall apparent benefit. Right? And so it basically, if you remove the non-luminal tumors, the magnitude of the chemotherapy benefit in ER positives is greatly reduced, but it is still statistically significant. Right? So the non-luminals can't explain all the chemotherapy benefits seen in ER positives.
Thank you very much. Thank you very much.
Thank you.
Разрешите мне представить его мальчика. 2 года назад мы с группой из нашего института, доктор Дернов, доктор Барыш, посетили клинику, где работает в Финляндии хирургом. Она считается одним из самых выдающихся хирургов-пластиков, в том числе в области рако-молочной железы. Посмотрели операцию ее коллег и, в общем, рассчитывая на сотрудничество в области здравоохранения с Финляндией, в частности, в самом Вильно, где блестящая клиника, где работает, она часто выступает на различных конгрессах. И вот мы имеем счастье послушать ее на нашей конференции.
Mrs. Chairman, dear Professor Simtratso, dear colleagues, I thank you so much for this invitation to participate in your fine congress. It is a special honor for me to introduce you my study about microneurovascular muscle sparing transplant in breast reconstruction. I bring you welcome from Savonlinna, Finland, from beautiful Lake District area. We have over 500-year St. Olaf's Castle there, and every July we have famous opera festival inside the garden of the castle. I'm a plastic surgeon. I have worked all my professional career with breast cancer patients. Yesterday I was listening to your excellent performances about breast reconstructions. Even after my many years, working years, I need to say that it is difficult. I want to point 3 main things about breast cancer surgery. First, the main point is an accurate breast cancer diagnosis. How big is the tumor and how it is placed in a breast. Unfortunately, we know it better after the surgery. But the first operation is the patient's chance, and it's very important how it is done for her rest of her life, and the patient will recover from the disease, from the cancer disease. Second main point is good planning of operation and patient selection. Is it possible to make a beautiful breast with good, healthy margins with oncoplastic surgery or not? If yes, please do it. And correct asymmetry from the opposite side if it is needed. The third main point is a technique. If you can save good blood circulation into the skin and make a radical tumor surgery, you will avoid most of the complications, not depending on the method which you use. I use all methods for breast reconstruction, but even implants have become too mode back. I mostly use patients' own tissue. And I think this horizontal abdominal free flap is one of the best reconstruction material. This skin and fat tissue underneath is very soft and makes good shape and the consistency for the coming breast. My first microvascular free flap I made with my senior colleague Liisa Tuominen in year 1991. But I found out that the reconstructive breast was, its sensibility was very poor. And I started to study neural anastomosing techniques in order to get sensing breast. And my first neuro microvascular free flap